Good evening, everybody. My name is Dr. Michael Detola, and I'd like to welcome you to Modern Post and Core Placement. I'm the Director of Clinical Education at Glidewell Laboratories in Newport Beach, California. We're probably the biggest laboratory in the United States, maybe in the world, and I know that we have some international guests attending the webinar tonight. So for those guests and for our U.S. guests as well, I wanted to share some statistics with you about what's going on here in the United States in terms of restorative dentistry. So if you look at the last, say, 6 years, back in 2007, if you look to the left, here at Glidewell, and we work with dentists in all 50 states, here in the United States, 65% of the crowns that we made were PFMs in 2007. And if you look just underneath that, 23% of the crowns that we made were all ceramic crowns. And if you fast forward to so far this year, 2013 year to date, you'll notice that PFMs dropped from 65% in 2007 to 19% of the crowns we've made so far this year. That's pretty dramatic. That's almost as if the FDA or the Centers for Disease Control came out with a warning or a statement that PFMs cause cancer or premature senility or erectile dysfunction or something horrible, and that dentists just turned and ran from PFMs. But nothing like that happened. Dentists just started prescribing something else. And that something else you'll see right underneath it, because all ceramic crowns went from 23% of what we did in 2007 to 77% of what we've done so far this year. And that's amazing. I've been at a dental school for 25 years now. I just always assumed that the PFM would be the restoration that would be the majority of the restorations I would do for the rest of my career. I never dreamed that it would become 77% of what we would do at the laboratory here, because if you've been practicing for 20 or 25 years like I have, you've probably been burned by a couple different all-ceramic crown systems over the years. You've probably been told by the reps for these all-ceramic crown systems that, hey, don't worry, doctor, this is a newer, stronger one. This is better than the last one. This won't break. Go for it. Don't worry about it. And then had some angry patients when, in fact, those all-ceramic crowns did break and you had to replace them and nobody was there to pay you for your chair time. And it was a pretty disappointing feeling. But things have changed now. Obviously, they've changed because 77% of the crowns that we're making are all ceramic crowns, and that's going to tie in a little bit later when we look at post and cores, because that forced us to change from the metal post and cores that most of us were taught in school, or the gold cast post and cores that most of us were taught to make through the laboratory, to go to a more aesthetic post and core like the kind that we're going to be looking at today. So this is a big date in dental history, at least as far as the lab industry is concerned. August 17th, 2011. And this is something that the rest of the dental industry really hasn't even taken note of yet. And the reason this is a big day is because that's the actual day where PFMs, when you compare it to the monolithic all ceramic, so we're talking about IPS EMAX, and Bruxer, the solid zirconia material. If you combine those, that was the day that they passed up PFMs in terms of sales, and they've never looked back. So that was the day where PFM crowns lost their dominance in the U.S. restorative market, August 17th, 2011, and it's never looked back. In fact, later that year, in December 2011, Bruxer on its own, that solid zirconia crown, passed up PFMs on its own and has never looked back, and that gap continues to grow. And then later in 2012, a few months later, February 2012 to be exact, EMAX crowns passed up PFMs on their own and have never looked back. And so it's amazing to see how the PFM, through no fault of its own really, the PFM served us well for 30, 40 years, but all of a sudden these two high-strength all-ceramic crowns that could be cemented, they did not have to be bonded into place, and they looked good. EMAX looks great. Bruxer actually started off looking pretty ugly in the beginning, has gotten better looking over time as time has gone on, but it's been two materials that have really kind of taken over and forced us to be more aesthetic. And the crazy thing, when you look at this graph, is that the Bruxer crowns have actually been outselling the Emax crowns about 3-to-1. And it's the uglier crown, and it's the stronger crown. It's 3 times as strong, but it's definitely a little bit uglier. But you can just see how the Emax crowns, that's an incredible growth curve as you look there, and the Bruxer crown's the same way. That's not quite as compressed as the graph before it, but both of these have just been taking off. And so that's forced everybody to go to a more aesthetic post and core system, because once you start putting more translucent crowns on these anterior teeth, we need to concern ourselves more with the stump shade. And anytime we're going to take a tooth and perform endodontic treatment on it, we want to make sure that we don't darken that stump shade by putting a metal post and core on the inside of it. So let's look a little bit at devitalized teeth that have had endodontic treatment. And let's look at some numbers and some studies about these teeth, and then we'll start talking about the post and cores inside of them. So a couple studies, just looking through the research, talking about the quality of a coronal restoration. So we're talking about a full crown on the top of a tooth that's had a root canal treatment. Some interesting numbers. Ray and Trope found that if you looked at over a 15-year period and you found a combination of a tooth that had a good restoration on the top of it, so a good crown with sealed margins, and a tooth that had good endodontic treatment as well, it resulted in an absence of periapical inflammation in 91.4% of the teeth, whereas the teeth that had leaky crowns and bad endo resulted in an absence of periapical inflammation in only 18% of the teeth. So that's a pretty huge difference between those two, as you would expect. But the really surprising number is if you have teeth with poor endo, but it had a good crown on it with sealed margins, you had a success rate of 67%. And so they concluded that apical periodontal health depended significantly more on the crown than on the technical quality of the endo treatment. And that's really interesting, and that fascinates me as somebody who practices inside of a dental laboratory, that the crown ends up being the more important indicator or predictor of whether or not that tooth is going to be in the mouth for a long time. Hogan Dwyer found that 1 to 2 millimeters of tooth structure coronal to the crown margin significantly improved the fracture resistance of the tooth. The ferrule reduced root fracture by 1/3. And so we've been taught about ferrule effects. So that's the magic number that we're looking for, is 1 to 2 millimeters of tooth structure. And by the way, if you are going to be taking the CE test afterwards to get your 1 unit of CE, those last numbers and these numbers, this is probably where the questions at the end are going to come from. So Chung showed that a post should be primarily used when there's insufficient tooth structure to support the final restoration. And that's really the only time we're going to be using posts. It's not going to strengthen the root. There's now been 4 studies that I've seen just in the last couple of years showing that endodontically treated teeth are not more brittle than vital teeth. That's kind of an old wives' tale that we were all taught in school. A post is not going to strengthen a tooth because it's brittle. The only time we're using a post is to attach a core to the tooth. That's basically it. Goodacre out here at Loma Linda, Charles, showed that post length should be as long as the clinical crown height. And so typically the post should end halfway between the crestal bone and the root apex. So we're not trying to get it all the way down into the apical third. That's how a lot of fractures happened. John Sorensen showed short posts have poor retention and actually transmit larger lateral forces to the remaining root structure. That's kind of counterintuitive. Why would a short post transmit larger lateral forces to the remaining root structure? Well, the longer the post is, the larger the surface area, and so it spreads out those lateral forces over a longer area. So shorter posts, you would think, might be less damaging, but they actually concentrate those lateral forces to a smaller zone and actually cause more problems. And Krupp showed that increasing the post length is more important than the post diameter for retention. And so really it's not about getting the biggest post we can in there. It's about getting the proper length, and again, halfway between the crestal bone and the root apex. And so when we think about, wow, let's really try to get down, let's try to get that halfway, there's something to be said for the length of the gutta percha that's left in the root canal. So it's thought typically by the researchers that the length of it influences the success, and the consensus seems to be that a longer fill, or the more gutta-percha we leave in there, creates a better seal. So DeClean stated that 3 millimeters of remaining gutta-percha is the absolute minimum that we should leave in the canal, and preferably 6 millimeters should be left in the canal. And at times this is going to be at odds with those measurements we were talking about for how long we want our post to be. And so we're going to have to go back and forth between, should we go ideally and leave 6 millimeters of gutta-percha, or do we want to get halfway between the crestal bone and the apex with our post? And that's going to be a judgment call on your part. Mashinov did a study, and this is really interesting. He measured the influence of the gap between the end of the post and the gutta-percha. So once you insert the post after removing the gutta-percha and creating your post space, it was interesting. They actually measured the space between the end of the post and the gutta-percha, and the best outcome in these teeth was when the post was in contact with the gutta-percha, 83% success. If they had a gap of 0 to 2 millimeters between the apical portion of the post and the gutta-percha, the success rate dropped to 53%. And if they had a gap larger than 2 millimeters, the success rate dropped all the way to 29% from a greater than 2 millimeter space between the post and the gutta-percha. And most of us, certainly I never really thought for, I don't know, the first 20 years of my career about the space between the post and the gutta-percha. I just figured, it's going to fill with cement, not really anything to worry about. And it turns out that's not true. And so Revy and Rothstein did an epidemiological study of 1.4 million endodontically treated teeth, and amazingly found that 97% of the teeth remained in the mouth after 8 years. That's an impressive stat. That's way to go, GPs. We're doing most of those. It's not the endodontist, so we can pat ourselves on the back. Complications occurred in teeth without any occlusal coverage in 85% of the cases. So in other words, the teeth that had problems afterwards, 85% of them never had a crown put on afterwards, any kind of occlusal coverage. And Aquilino found that teeth not crowned after the root canals were done were lost 6 times more often than the teeth that were crowned after obturation. Those are the people who get out of pain and just never have it finished. And Peter showed that in his 10-year prospective clinical trial, 94% survival rate post-encores with a crown. So when that all gets finished off, things will last a long time, and the longevity of the post-encore restoration is influenced by the amount of dentin height after the preparation, and that plays into the Farrell effect as well. So certainly there are times where we have to do crown lengthening so we can get that millimeter or 2 of dentin tooth structure back again. So the all-ceramic veneers and crowns forced the move to the more aesthetic post and core, and Ferrari actually studied the difference between the metal post and cores and the glass fiber reinforced post and cores 4 years after placement. The metal post had a failure rate of 16%, and the failure rate was 5% with the glass fiber posts. And they figured it was the difference in elasticity between the two materials, why the glass fiber posts were more successful than the metal posts. And Spazin showed the long-term success of the post and cores is linked to the behavior of the post under loading, and tested glass fiber and zirconia oxide, 2 aesthetic post options. Zirconia came out right when we wanted to have our first tooth-colored post, but you know, the Bruxer material that I was talking about earlier is made out of zirconia, and it's very, very strong. And you can see the bottom 4 posts in that drawing are zirconia posts put under load. And those red areas are the zones where we get the concentration of stress. And it's right, not only can the post break right there, which is a difficult place to get that post out if it does, but it puts a lot of stress on the tooth right there as well, and we can get a root fracture there. And those top ones are actually the glass reinforced ones. And so the Rebuilda post system that you're going to see demonstrated tonight actually is one of those posts, and so it flexes more, and that elasticity matches dentin, and so that's something that we want to see. So the Rebuilda post system contains multiple products. It's got the Rebuilda post, the fiber reinforced resin post, the Futura Bond DC dual cured self-etch adhesive that we'll be using, the Rebuilda DC, the dual cured core build-up material composite, in an auto-mix delivery system. And so the fiber reinforced resin post, you can see all the fibers on the inside oriented, spread together, gives you nice lateral strength, and it's very easy to use. That dentin-like elasticity makes it so when the tooth is put under load and you bite down on something, We don't get that concentration of stress like we did with the zirconia oxide post, so we don't cause that kind of stress on the tooth as well. A dentin-like translucency, which is nice. We want light to go through it, unlike metal. And we also want to be able to cure it when we're curing with our curing light and have it transmit the curing light down to the cement. Even, all our dual cure cements, even though they're dual cure, if you ever want to test your dual cure cement, squirt some dual cure cement onto a pad and then throw the pad into a dark drawer, go to lunch and come back and check it. I guarantee you it will not be set. Even though we call all these things dual cure, they still need some light cure activation to start the cure and get it going all the way. And so we want that post to carry the light cure all the way down to the bottom. Okay. We also want to have high radio opacity, and you can see as we've got the radio opaque nature over here, we've taken an x-ray of the post next to the tooth, and you can see that it's pretty close in terms of radio opacity between the two. And that looks nice. That's what we'd like to see. We want to be able to clearly identify it. And the anatomical shape of the post fits well into the canal. And we've got our color-coded drills with our three sizes there, the 1.2 millimeter, the 1.5, and the 2 millimeter. And you'll see these used in just a minute. And so having a self-etch adhesive that's unquestionably compatible with the core material is more than a great feature of this system. I think it's mandatory, and there's been a lot of dentists, including myself, who have gotten into trouble over the years by trying to kind of mix and match bonding agents with different dual cure core materials, and Gordon Christensen and Michael Miller have had to look into it, and because of different chemical initiators, there's been a lot of these materials not setting up, and so you want to make sure you stick with the same system. And I like that the Rebuilda system comes with all these ingredients in the box, and so you're able to use it with a high degree of confidence that you're going to get complete conversion and setting of these materials. Both the adhesive and the core material dual cured, and so they can be used to cement the post and form the core. So unlike in the old days where we had to use one cement to cement the post to the inside of the root canal space and then another material as our core buildup, we're now using the same resin material to cement the post and create the buildup itself as well. We'll also see a case where we use the Grandio Core dual cure. This is the newer material from Voco. And Voco is sponsoring tonight's lecture, which is why you'll see their products featured tonight. It's a flowable, dual cure nano hybrid core buildup material. It can be used on vital and non-vital teeth. Tonight you'll see it primarily featured on non-vital teeth because we're talking about its use with posts, but this is what I use on vital teeth as well. And again, we can lute the posts because of the long endo tips on the auto mix syringe. So you'll see later in the clinical case that we've got a nice long tip here, and this will slide almost all the way down. That's about 14 millimeters long. And so we can get it down into a canal and get cement all the way down there, which is nice. And this dentin-like hardness, which I really appreciate. There's nothing worse than trying to prep a crown after doing a buildup, and as the burr moves from the dentin onto the buildup material, if it's not hard enough, the burr dives into the buildup material and ditches the prep and really screws it up. So we want something that's very hard, so that if your eyes were closed, you could not tell the difference between the burr being on the tooth and being on the buildup material, and that's highly desirable. And that's because it's 77% filled by weight, so that it's very, very stiff when you cut on it, and it's very radio opaque. In fact, it's the same degree of radio opacity as the post, so it appears as radio opaque as the tooth on an x-ray. And it's available in 3 shades, Dentin, blue and white. I use the Dentin under translucent anterior restorations like Empress or Emax or feldspathic porcelain restorations. You can use the white under Bruxer, like solid zirconia materials, or placing, because they don't, they're not as translucent as Empress or Emax, and as a result you won't be able to see them showing through. Sometimes they'll even place it inside of an endodontically treated tooth that was done many years ago to try to lighten it up from the inside after a walking bleach technique. And there's a blue buildup material too. This is on posterior teeth with subgingival margins where it's critical to be able to see where the margins are and to see where the tooth structure and the buildup material come together. So with those three colors, I've got the buildup materials that I need for just about any situation that I'm going to run into. So there's several different advantages of core buildups. And in the old days with PFMs, we could decrease porcelain fractures because of any time that we had metal that was going to be thin, the porcelain would be too thick. In fact, we've listed, I'm not going to read through all of these because we came up with this list one day in the laboratory. I think we ended up coming up with almost 17 different reasons why we felt it was so important to do build-ups, and why it was really something that for us was going to be important for people to do and be able to build things up. And you know, we see little prep issues in the laboratory from time to time where we find ways where dentists will make little things, and I used to make a lot of these mistakes too. And this is one of the more common ones. We'll see an anterior crown like this one, an unesthetic PFM, and we'll take off the PFM and we'll see this. We've got an inadequate post here, very short when you look at it on the x-ray, but I'm looking at the prep and it's underprepared in the cervical third, but it's overprepared in the incisal third. And this is what happens when you try to take too large of a burr interproximally through here. You have to tilt it over, so you over-prepare in the incisal third and you under-prepare the cervical third, and you end up with this strange kind of situation where you've kind of made two mistakes, one here, an over-aggressive one here, and an under-aggressive one here, and they both lead to problems. So we take that old little metal kind of post out, we prep that post space, and then, of course, we put a fiber post in and build it up. And now you can see we've gotten less aggressive in the incisal third. And so we've gotten rid of the over taper, but we've gotten more aggressive, and correctly so, in the cervical third. So we've prepped enough here so that we've got a chance of the material actually looking like a real tooth. You have to reduce enough in the cervical third so the emergence profile will be correct. And we have enough thickness here for the all-ceramic crown so that it won't break. And you compare how this looks to how it looks here, where there just wasn't enough reduction here to have a good-looking crown. And that's what gives away a fake crown, is the gingival third and the under reduction there. Okay, so we're gonna take a look now on a clinical video and see the system in use. And so that's the Rebuild-A-Post system that you see there, where all the different products are combined into that box. And so I'm taking off some old crowns here on a patient of mine, and we have 3 preps there that are in pretty good shape. And I'm using a Cavo Sonic Scaler there. I love that Cavo Sonic Scaler to clean off some temporary cement. I can do so much with that Cavo Sonic Scaler. And that's the 0.7 millimeter post reamer. This isn't a post drill. I'm just using this to remove some gutta percha. And this is included in the Rebuild-A-Post kit. And so the camera switches over because oftentimes I will take my head and turn it to the side like that. I'm just trying to visualize the angle that the root canal is at. Now this is a safe tipped instrument, so you cannot run it into the canal wall or run it out the side of the tooth or anything like that. It's just following the path of least resistance. So I'm going into the gutta percha, but oftentimes I'll want to see how deep we are as we're using this and removing it. So as I'm taking out the gutta percha and put it in, this is in my mind, one of the big advantages of digital radiography is I can just have my assistant snap a picture and in 2 seconds see exactly where we are. So I was at my desired depth, so that was the 1.2 drill post, and that fell right into place. So I swapped it out for the 1.5 millimeter drill post. And this is a lateral incisor, so we know that we're probably not going to end up, on the largest size. And again, we've seen in that study that it's not about the diameter of the post. I'm just going to mark a little bit above where I expect the incisal edge of that prep to be, just so we can take some of that post off before we put it into place. And again, I'm just going to cut that off. And you can see how that fiber post is. You cut through part of the resin, and the fibers are still kind of holding that on as we do that. Now I'm just using a little alcohol here to clean anything off that might have been on there, contaminating that. That's the ADEC warm tooth dryer that I'm using. I love that because that is never had any oil or handpiece go on there. The ceramic bond that comes in the kit is now being placed onto the post, and we're going to be able to bond to this post because it is a resin post. And so we're putting the primer on, and now we're pressing down on the Futura bond. So we squeeze it where it says press here, and it combines the two chemistries together. And then I'm going to take the blue brush, which I'll use on one part of the tooth, and just make sure I've mixed those together. And then there's a brush that looks a little like the endo tip. It's kind of like an endo brush for going down in the canal. It's a long, skinny, kind of needle nose brush, and I take that in. And it's a little more gentle brush, so I like to go in and mix it up with the blue one, and then I take that long one. And it almost looks like an endo file. As you can see, it's nice and long and tufted. And so once I've coated that with the bonding agent, with the dual cure self-etch bonding agent, we're going to go in there. And this is nice. I remember in the old days trying to put phosphoric acid in the middle of the canal, inside the canal, and then trying to rinse it out again, which was tough because it's tough to rinse things out of a blind alley, if you will. You know, it's tough to irrigate out of something that's a closed-end system like a root canal system. So we use that brush on the inside, and then we use the bigger brush on the outside of the tooth, and obviously we need a post here. There's the ADEC warm tooth dryer. Just thinning that and using that to evaporate some of the volatiles. We want to make sure we don't pool the bonding agent down there, or the post won't seat all the way. So use a paper point to make sure you haven't done it. Now you don't want to cure that yet. You just want to go ahead and place that's the Rebuilda DC dual cure material. And so we're squirting that into it, and then we place the post into the material, into the Rebuilda DC, and you're going to give it a little cure here. And you can just cure it for a second or two, and if you want to clean up any excess, you can, or I'm just going to cure it and give it a bigger cure than that. And then you can either do what I call the soft serve ice cream approach, where you just start putting it on freehand, and we do that sometimes, or we'll do this. That's a Rebuilda form where it contains the amount that you put on there. If I don't have any tooth left, like we don't have any tooth left here, I'm going to use a form like this. It just makes it a lot easier to contain it and keeps it from creating a huge mess. See where I had that void right there on the facial? I just take another tip and put it on there on the Rebuilda DC, and you can just add to it because it's resin, of course, so we can add resin back. We still have that oxygen inhibited layer on the outside, so I'm just adding a little more resin to the outside, to that void, and then we cure it again. So we could continue to add in more places if we needed to, and then we cure that, and then we'll begin the shaping. So if I do have some tooth structure left, I usually don't need to use that form because the tooth itself will kind of act as a form and will kind of guide me as I go to place the buildup material in place. And so since we're going to take the impression, I put that first 00 cord in place. That's from Ultradent. And this is a 2E cord from Ultradent as well. We put this on top. I love that 2-cord impression technique, and since I have an electric handpiece, that's a Cavo Electrotor handpiece, I can turn the water off, turn the speed down to about 2,000 RPMs, and that's my favorite burr, that 856025 burr, and going very slowly at 2,000 RPMs, you can really dial in that margin without having to do much work on the tooth, and without the water on, you can see exactly what you're doing. So we're putting in the 00 cord around the rest of those teeth as well, and then the number 2 cord going in around the rest of those teeth as well. That bottom cord going in first ensures that when we take out this top tooth, there should not be any bleeding or very, very little bleeding around these teeth, because it's only when the very last cord comes out that the bleeding really starts. So in a 1-cord technique, when you take that 1 cord out, there will in fact be a lot of bleeding. And the two-cord technique, when that very first cord goes in, it provides apical retraction of the tissue, and it also stops bleeding from occurring if you put another cord on top of it. This cord, this top one that I'm putting on top of it now, provides the lateral retraction of the tissue. This is the one that really creates the space for the impression material when it's removed from the sulcus. And you'll see that in just a minute. This is an anatomic ComproCap. It's anatomic because it has the cutouts interproximally for the papilla. It's not just a round circle. It's actually got those cutouts there so we don't put too much pressure on the papilla. And you can see as my assistant pulls these cords out interproximally, like right there between 8 and 9, you can just see the huge amount of lateral retraction in between the gingiva and the tooth structure there, and it makes it very easy to get that impression. And because that bottom cord is in place, there won't be any bleeding. If that bottom cord was taken out right now, there would definitely be some bleeding. I don't care how healthy the patient's tissue is on the surface or at the free margin of the gingiva. The fact remains that at the base of that sulcus, there is still going to be some inflammation. There's no doubt about it, regardless of how healthy the patient's gingiva is. So in a one-cord technique, or when that bottom cord comes out, there is definitely going to be some bleeding. So to me, being fastidious about taking good impressions, the two-cord technique is really kind of mandatory for me to go through and do that to help us get a really good impression. So again, you can see the components that come in the kit. We've got these are the long brushes right here that you saw go into the canal. And again, we've got the 3 drill sizes that sit right here in the reamer that we went and took out the gutta percha with. And then we've got the Futura Bond DC, the dual cure self-etch material here. And then the bonding agent that we put on the post itself. And that all comes along with the posts, which are over here in the color-coded corresponding sizes to the drill itself. And again, by having all of those in the same system, you're assured that your dual cure bonding agent is in fact compatible with your dual cure buildup material, because there's a lot of dentists who had a lot of problems with those materials not working that smoothly together, and that's definitely an issue. This is one time where you definitely want things to be working smoothly together. There's no worse feeling in the world than this is another case that I did the other day on an anterior tooth where we're using a slightly different approach to the same way. So I'm going in with that first drill, the 1.2 millimeter drill, and removing some gutta percha. We went in with the reamer, and this canal is just too big. This is on a central incisor on a younger patient as we go in and remove a little more gutta percha. But I was going to say there's no worse feeling than taking a temporary crown off and having a buildup come out with it. Well, I guess there's one worse feeling, and that's taking off a temporary crown and having a buildup and a post come out with it. That's really heart-wrenching. So we're measuring the 13 millimeter working length on that nice little thermophil ruler that I like using. And so we're going in and just going in and creating the post space. These I really like the drills in the Rebuilda post system too. They're very sharp and they cut very well and they're safe tipped. And they match the post size very well. And it's just a nice, clean, easy to use, straightforward system. And we're going in here and just kind of creating the space. Again, not really forcing it any more than we need to go. Looking for that halfway between the crestal bone and the apex. We're balancing that on one side against the other side of our mind, knowing that we want to have a minimum of 3 millimeters of gutta percha remaining in there, and optimally we would like to have 6 millimeters of gutta percha. So we got to the Rebuilda Post 20, so the 2.0 millimeter drill, and now the 2.0 millimeter post as well, matched that size. And again, you can see the anatomic shape of that. So I'm going to take that post and again clean that off with some alcohol. I've got a stopper on there at the proper length. And so just making sure that everything is clean by putting some alcohol on there. And again, with that ADEC warm tooth dryer, so that's not one of my regular handpiece hoses. I had my repair guy come out and put a new hose on that had never been used for a handpiece, so there's never been any water or oil in that particular hose. So anytime I use it for a bonding procedure like this with that ADEC warm tooth dryer, there's a venturi inside of that that heats up the air. So for these bonding procedures, I know I'm always getting good, warm, clean air. And you see me using it again. That's never had any oil through it, and I know there's no contaminants going through it, and that's really important, I feel, as you go through these bonding procedures, especially on dentin, I feel. Probably more so on vital teeth than non-vital teeth. But again, I'm pushing down on the Futura bond to activate it, combining the two components, and then going in. And you can see that long, thin brush there. That's a really interesting shaped brush. Not a lot of companies have a brush, and I can't think of too many actually, or anyone that has a brush like that, and it allows you to get all the way down into that canal, or as far down as you need to get where the post is going to be going as well. And so we've got that dual cure bonding agent on there, and then you take the blue brush and it carries a little more of the material, and we're going to carry it around to the margins, anywhere we're going to want the buildup material to be able to bond as we go around here. So again, we do have some tooth structure left. So this is one of the ones that I mentioned earlier. It probably doesn't need one of those rebuild up forms. You could certainly use it if you wanted to, but this is going to be, one of the cases where I do kind of a soft serve. And so the paper point, we want to go down to the bottom of that and make sure it doesn't pool up. In fact, this canal is so big that I felt like I was swimming around with that end of the paper point, so I decided to go with the larger end as well to make sure that I didn't have any pooling anywhere. It was just a huge, wide canal, and at times in there it just felt like there was just too much, absolutely too much space. So the GrandioCore gets squirted down into the inside of the canal with the tip, and then we seat the post down into the inside. In fact, it was so big, I spent a lot of time with the mirror looking at it to making sure the orientation of the post was correct, because there was so much play in a buccolingual direction. And so once I just cure it for a second or two, now I take the GrandioCore, and again, this is what reminds me of kind of a soft serve ice cream. I'm just kind of going around and around the post, and then my assistant cures it, and I put a little more, and she cures it. I usually don't continue to squirt it as she's curing like that. But I was almost towards the very end. I thought she was just going to cure it for a second or two. And so that soft serve way, you end up with extra material on there. You definitely end up with more material that you need. But usually it'll take 2 or 3 increments as you put that material on, and you can see it doesn't take all that long to clean up, and then we're going to fix that composite on the tooth next to it and prep that tooth as well. And so it's a straightforward system that allows us to quickly and easily get it in. And you can see it's the one there on the right. And so we're down. We've got 5 millimeters, almost 6 millimeters of gutta percha left in the apical third there. But again, that was just a huge, wide open canal. And really, when we were in there preparing that post space, everything we were doing was just down kind of in the apical third. And really, we were only kind of preparing maybe 3 millimeters of tooth space at the most. And it was all kind of in the apical third of the tooth space. One last interesting case here. This was a case that is kind of an interesting approach, because it was a little more difficult to deal with than a lot of the cases that I've done before, because we ended up having to do multiple post and cores here. And this is something that we have to do a couple times a year, and I never really had a great way to be able to deal with it. And we were using some lab fabricated temporaries here, and this was something that kind of occurred to me on the fly, and this has kind of become my standard way of doing this since then. And you can see the patient's got really short, you can see that's a threaded post there. There's no post in the one tooth, and the threaded post really isn't engaging the walls of the tooth. You can see gutta percha on the side of it, and I'm not a big fan of threaded posts, but they are supposed to engage, the tooth a little more, not just the gutta percha. You can see some apical radiolucencies there. You can see that the margins didn't appear to be sealed necessarily, and we already found out that the crown might be more important than the quality of the root canal when it comes to long-term healthy periapical tissue. So I had the patient go see a endodontist who wanted to do retreats on those and wanted me to redo the crowns and created some post space. So he went and had that done, and now we're taking off the crowns. And basically, the endodontist left the post space for us, and so we're trying to figure out here what the best way for us to do this is. And tooth number 7, that lateral incisor, is a pontic that was hanging off of there, and that's why he had that little lingual anti-rotational feature that you saw there, that little finger that was on the lingual of the cuspid. So we're just going in now with a 57 carbide and getting the chance to kind of remove what's in there and kind of access that, access the space that was placed by the endodontist to see how much room he gave us and see what's going to fit in there. So we've got our X-ray where we've measured the length of the post space created by the endodontist. We've got the length of measurement that he used when he got to the apex when he did the root canal, and we're kind of using this to measure from where we anticipate the incisal edge to be, from where we're going. And so now we're going to fill some cement into there once we've measured and cut the posts, and we're placing the posts in. And I wasn't totally confident at this time. This is before Voco had their material, or at least before I had Voco's material, and I was not confident enough, like I am with Rebuilda, to be able to use the same material to cement the post or to bond the post into place and as the build-up material. So today I'd use the same material for both of these. Now what you see there is a vacuum formed stent, and this is what the lab used to fabricate the lab fabricated temporaries, the biotemps that we're going to use here. They put that on the models when they took the pre-op model and prepped them back to make the temporaries. So they have made a set of temporaries for me that fit on a set of stone models, and that's the suck down of those stone models. So first of all, I'm trying that onto these teeth to make sure that the posts do not come in contact with that anywhere. And I can see that a couple of those posts, especially on the lingual, are coming too close to that suck down. So I'm putting the suck down back on to make sure I have enough clearance between that stent and the posts, because if I don't have enough room now, I won't have enough room later. And there's the temporaries being tried into place. So I know that those posts that are in there, they're going to have some buildup material around them, but there's a pretty good chance the posts are going to be pretty close to the surface of the preparation when all is said and done. So I need to make sure that those temporaries that you saw are going to fit passively over my preparations. I know that the temporaries fit passively on a stone model that had that suck down made over it. So basically what I'm going to do after I etch and put the bonding agent on the teeth and the posts is take that suck down that was made on the model that the temporaries fit passively on and fill it with the buildup material, and then stick that onto the teeth with the posts in it and then cure through that. And so I realized rather than trying to hand build this and then put the temporaries on top of it, even though this was designed by the lab as a reduction guide, they really wanted me to use this to put it on top of the preps to make sure I'd reduced enough. I thought, well, why don't I fill it up with the buildup material and then use this to help me get my preps. Now, they're all connected here, obviously, so it's one big mono tooth, but at least I've got my basic shape kind of given to me here, and hopefully the correct facial and lingual dimensions, so that when I go in and prep these, basically I've made a mold, if you will, of the stone model that the temporaries are put on. And by the time I separate these and put enough reduction here, especially in the gingival third. And really what I'm looking for is that 2 millimeters of apical dentin that we talked about earlier, and I can see those fit in passively now like I want them to. And I'm going to reline those temporaries, either with a methyl methacrylate, or today I reline those with a bisacril. And I know they're going to work well with the bisacril because today I have a bisacril that has a gel state, and so I can use that bisacril and pump it up and down and know it's not going to lock into place, because that's always a fear for me. And this is where you can tell if your post and core worked when you take off your temporaries, especially when there's 4 of them splinted together like that, and you're going to pull those off. Of course, if you use Duralon as your temporary cement, then you're really going to find out whether or not you've got those bonded into place correctly. That's going to be the time where you're really going to find out, because if you pull them off and your buildups come off in the temporaries, that's when you know, well, wait a minute, I really didn't bond those into place very well. So it's a neat way, because you can see that we've now got something where it kind of helped us with the shaping of those teeth by having to make those preps fit underneath those lab fabricated temporaries. So not only did we end up with some nice temporaries for the patient because the lab made it, the lab always does a better job on those than we could do chairside. In fact, the way the lab makes those and the reason they look so good, you can tell I practice in the lab because every impression I take is in a custom tray. Otherwise, that probably wouldn't happen. But when we make those temporaries, we take hollowed out denture teeth and then we backfill those with acrylic. And denture teeth are gorgeous. I mean, they're the best looking teeth in all of dentistry because they don't have any coping material underneath them for the most part. Until Emax, they were probably the best looking teeth that we had in dentistry. So when we take those denture teeth and hollow them out and backfill them with acrylic, there's a reason that those lab fabricated temporaries, those biotemps, look so nice. So really we're using that to kind of shape the preparations and what they look like. And so it ended up working out really well in the case, and then we ended up putting in his permanent restorations. And so as a result, we ended up with preps that looked nicely, and we're able to shape them and get those bonded into place. And that case is now probably almost 7 or 8 years old. So anytime now that I'm doing multiple post and cores next to each other, anytime I've got that kind of thing, because that's a lot of work to kind of hand build 3 post and cores next to each other and have the preps all draw and line up the way that they're supposed to line up. So anytime that happens now, I'm going to do that with that kind of thing where I have the lab fabricated temporaries made, and then use that suck down from the model that they were on to go ahead and do that technique that you saw there and use it to build up underneath it. By the way, okay, I see some people are sending in questions. We're going to get to questions in just a minute here. One last thing I want to show you. Here's a patient. You can see he had a full arch upper bridge in here, and you can see it's broken, obviously. And just quickly, I'm going to show you as we take off this bridge, and we end up going in and doing endo on a couple teeth, and there was a metal post left in this tooth, and I got the metal post out of there, and so we went in and we put a fiber post in there, again with a Rebuilda DC, and then shaped the post on this tooth. And of course had to take out the diode laser to create a little more space for the tooth, and then another metal post over here. I would have left the metal post in because we're going to do Bruxer on this guy. He broke that PFM bridge that he had before. That anytime I see somebody who breaks a PFM, I'm immediately going to Bruxer, to the full contour zirconia. That's the only thing will work in somebody who's well, cast gold will work in somebody who's broken a PFM, but most of these patients don't want cast gold. I know that I can leave metal like this under Bruxer. I've left cast metal post and cores under Bruxer, and it won't show through. It's the only material you can do something like that with. The only reason I'm taking these out is because they're really inadequate and very short, and there's so much space between the end of that post and the gutta percha that I'm afraid we're not going to have success. So I'm putting my fiber posts in because I like the elasticity of them. And you can see how dark this endo tooth is, and you can see how dark we are in the cervical third here. And so this was the first full arch Bruxer bridge that I did. And we just got 6 teeth there. We got these 2 molars, these 2 bicuspids, and 2 cuspids, and we're going to go in and try to put a full contour zirconia bridge. So here he is biting down on those orange wood sticks. So that is solid zirconia. There's no porcelain on there at all. And there it is. It's pretty amazing. This was almost 2.5 years ago. It weighed a ton when I held it in my hand. I couldn't believe it. I thought, wow, what's this going to do? I was afraid his head was going to be pulled forward, and I was hoping he kind of had some neck issues, so maybe it would pull it forward and do some good at the same time. But that's a big 12-unit solid zirconia bridge, and he has not broken or chipped it the way he broke his PFM bridge. And you can see that this is what early solid zirconia looked like. It had this kind of I don't know what to call it, opalescent look maybe. It's gotten more translucent, but it blocks out any color underneath it. It won't show any color underneath it. It does look more realistic today. It doesn't look as good as Emax, certainly, but the solid zirconia, considering there's no porcelain on here at all, it looks pretty darn decent considering it's pretty indestructible. You know, there's nothing that's going to chip off of here. You don't chip and size the ledges like you would off typical ceramics or anything like that. So it's an impressive material in that regards. And of course, as you saw, this and Emax combined now make up 77% of what we're doing here in the laboratory. So obviously, it's pretty impressive when you look at what's going on in terms of those materials.